Hello, I'm Paolo Tarantino from Dana-Farber Cancer Institute. So glad to be able to review our poster here at ASCO. And so this poster basically is trying to find biomarkers for predicting the prognosis of patients with stage 1 triple-negative breast cancer. And not everybody knows that stage 1 triple-negative breast cancer is very frequent. It's about 1/3 of all triple-negative diagnoses. And this is why we still don't have a great standard of care. We don't know which patients needs more, needs less. The first thing we did is looking at Dana-Farber, how many patients with this disease we found, and we had approximately 250 that had either stage 1 triple-negative or ER low, that we consider very similar to triple-negative. And when we looked at outcomes, we found that the patients with the smallest tumor, 5 millimeter or less, did not recur. Patients with intermediate T1B, meaning up to 10 millimeters, had a few recurrences, 94% recurrence rate from RFS at 5 years. The patients with T1C, between 1 and 2 centimeter, had the worst prognosis. Next step, we wanted to predict their prognosis with some biomarker. We found tissue from 117 patients with stage 1 triple-negative breast cancer, and we looked at two main biomarkers. One is a 10-gene score, immune score, that is able to correlate with the prognosis of patients, and we found that the patients that had basically the highest, either medium or high immune score, were found to have no recurrences at 5 years, whereas patients that had low CEG score, 10-gene immune score, had up to 11% recurrence rate at 5 years. Then we look at the proliferation. The more proliferative tumors were the ones that did worse compared to the least proliferative. Finally, we looked at a more established prognostic thing, that is tumor infiltrating lymphocytes. Tumors that had more lymphocytes, more than 20% of TILs, were the ones that did the best, 97% RFS at 5 years. Tumors with less TILs had a shorter RFS, 78%. And when you combine TILs and the immune score, once again, you can find patients that will never recur up to 5 years, and those patients set with recurrences. What are the next steps? First of all, validating all this, but most importantly, conducting, let's say, prospective trials to be able to see if we can omit chemotherapy in these patients with a very good prognosis, to find really which patients need more, which patients need less. Thank you very much.